I mean, this is the last time anyone wants to drop something to drop it now. Either drop it now or never. Good afternoon, gentlemen and ladies. How are you this afternoon?
Good, looking forward.
When I looked at the name, that is Disco PPM, I confused PPM with PMB.
Yeah.
And I thought that, well, these are the people who are going to talk to us about prescribed minimum benefits.
Yeah.
But it turned out to be that it's pharmaceutical benefit management. Yes, indeed. I wonder, would you be kind enough to introduce yourself and also to indicate to us who is going to lead the discussion?
Mr. Chairman, thank you very much for the opportunity to present. My name is Christa Rademan.
Yes.
I'm the CEO of Mediscore. I'm a chartered accountant by profession.
Yes.
I have been with Mediscore for the past 20 years and as the past 15 years as the CEO.
Yes.
I have two colleagues with me. They are both clinical people, and I'll ask them to just introduce themselves if you wouldn't mind.
Yes.
I'm Madeleine Lester. I'm a pharmacist by profession. My position at Mediscore is that of Executive of Funding Strategy.
Yes.
And
Yes. Thank you.
Afternoon.
Yes.
I'm Farid Lube, pharmacist by profession
Yes.
and a manager in the business development
Yes.
department.
Thank you. Okay, Mr. Rademan, are you going to lead the discussion? Or who's
I
going to-
shall be leading the discussion and doing the presentation.
Yes.
I'm trying to field as many questions as possible.
Yeah. Yes. When you are ready, you can go ahead.
Thank you, Mr. Chairman. What the base of our presentation is, let me just try and get it back. We were asked to present what PBMs do in the South African healthcare space and what our role is and why funders would appoint Mediscore to fulfill this very specific role of medicine management on their behalf. And we've therefore prepared our presentation in line with a brief that says we need to share with you our role and our results.
Yes.
Cancel.
During the course of the presentation, it's going to be divided into 7 subsections. I'll start off with the healthcare landscape, which will explain to the panel exactly where Mediscore fits in and what we do. The company overview with some information about our clients and where we get our income from. The role and the benefits of appointing a PBM or a pharmaceutical benefit management organization. Some information about the services we provide, our results, some information about our income model, and then last but definitely not least, the 4 statements of issues that we wanted to raise. I wanted to, at the start, compliment the panel for the statement of issues that have been published. Having been in the industry for so many years, I was very, very impressed by the comprehensive list of issues that were listed and published and distributed, and I really want to compliment you with the quality of the work done so far.
Thank you for the compliment.
If we could start with the healthcare landscape. The organization right in the middle is where Mediscore fits in. If I could give an analogy or a similarity, Mediscore is similar to the Visa or the MasterCard of the medicines industry. Same as what you would present your credit card to a Checkers or a Pick n Pay, and they would check against your credit card account. We fulfill very much the same role within the medicines industry. What is just different that in the banking space or in the credit card space, they would do 5 or 6 checks while you're at the store. In our environment, we would do a few hundred checks with that claim as it is processed by our software. So that what happens is that when you present your credit, or not your medical scheme card with a prescription at a pharmacy, that pharmacy will then submit the claim electronically in real time through to the medical scheme. But all medical schemes in South Africa don't have the infrastructure or the capability to be electronically connected to all of the pharmacies, and similarly all the doctors in South Africa. Therefore, they utilize an organization like ourselves to then validate and check the claim instantly while the patient is still in the pharmacy. And therefore, it's very important that all of the checks and all the validations are done while the patient is in the pharmacy. If you come back once the patient has left, the members made copay that was necessary. If you go back with any clinical information, the patient has left, is busy taking the medicines, and it could have negative clinical impact on the person. So it is therefore important that we carry a comprehensive patient record of all the members that we manage, and that we have a central processing engine that we apply all of the rules at that instant. So just to give you again, to give you a similarity, the whole transaction from the pharmacy screen to Mediscord, we process in 0.3 of a second, all of the rules that we implement, through to the funder, for them to give us final confirmation whether the patient has benefits, back to Mediscord and back onto the pharmacy screen, takes between 3 and 4 seconds. Long before the pharmacist is back from the shelf, the answer is back on the pharmacy screen. And late in the presentation, I'll share with you that we do between 100,000 and 150,000 claims per day, and from all of the pharmacies in South Africa. So all of the pharmacies submit in real time, the couriers and all of them, and then the dispensing doctors, they are busy moving into real-time claiming, but the majority of the dispensing doctors submit in electronic batch format. So that's a broad overview of where Mediscord fits into the healthcare space. If we could move to the next section, our company overview. We have offices in Centurion. We operate from a single premises. The organization was started in 1989, so we have been operating as a PBM for 27 years. What is important as well for today is that Mediscord is totally independent. We are not aligned or associated with any funder, any manufacturer, any pharmacy grouping. The shareholders comprise the management team and also a partner we call Pan African that are with us in the business and have been for a number of years. So we are totally independent in the role that we fulfill. And we're the largest independent PBM by then counting the number of clients that we have. We have more than 40 clients that we act for, but not the largest PBM in terms of the number of lives covered. In terms of the regulatory approval, we are unconditionally accredited as a managed care organization, and in fact we were the first organization in South Africa to be accredited. We employ 120 staff. Of the 120 staff, about 40 are clinical people, pharmacists or pharmacy assistants, and we also have a doctor on staff. The provider coverage I've shared with you is that all pharmacies, we have contracts with all of them, that lays down the rules and how they must submit claims to us and how we respond and our abilities and rights with regards to the contracts to them. And then I've said we process more than 100,000 claims per day. Our client profile is quite diverse. We operate in a number of countries. In South Africa, we have a number of clients, and we also have clients in Namibia and in Botswana. So in South Africa, our clients comprise medical schemes, some administrators, some managed care organizations, some health insurance companies, even some labor union sick funds for whom we manage the medicine benefits. And then we also fulfill capitation management, where the risk has been transferred to provider groups like PrimeCure or Medicross or so forth. We would do the medicine management and manage the risk on behalf of those provider groupings as well. So our client base are made up of these 45 types of clients. So it's not that we only operate in the medical schemes environment, we also have exposure to other non-medical scheme clients. And similarly, the exposure to the Namibian market and the Botswana market.
Just to make sure that I understand what
Yeah,
your
sure.
role is. So if the medication that I am requesting from the clinic, I mean from the pharmacy, gets rejected, I can call you.
For the clients that are with us, we are the entity that decides. So we are the entity that will decide whether the claim pays, whether it doesn't pay, to what extent it pays, whether there's a co-pay applicable, whether there's formulary applicable, where there are DSPs involved. So all of the rules applicable to whether it pays or it doesn't pay, that is Mediscor, and we make that decision. When we switch into the medical scheme, we only want to find out whether there is money available, whether it be on your savings account or on your chronic benefit or PME benefit or oncology or whatever it is. But we are the entity that makes the decision to pay or not to pay or to partially pay. That is our duty.
But all I want to know is the number the telephone number that's here, is that the number that I can call?
If you are on one of our clients, then yes.
Yes, I understand, yes.
So a BBM has a number of core functions that we fulfill, and I do acknowledge the fact that a lot of people in the South African industry, and similarly the population in South Africa, don't necessarily even know that an organization like Mediscor exists behind the pharmacy screens, because we're not out there and people don't communicate the fact that there are such a company that actually apply these rules. So what we do as our core functions is we would therefore then establish all of these electronic interfaces. There are about 2,800 pharmacies in South Africa and about 10,000 GPs. If you add some of the other disciplines, you could get to 14 to 20,000. But the ability to then establish these electronic interfaces, that's part of our duty and our responsibilities to establish the connectivity for the claims to flow. We would then, similarly as the next task, do the claims processing and adjudication. So as I've mentioned, it's our duty to decide whether the claim pays or not, and the funder relies on us. That whatever we decide, that is what is deducted, and whatever is finally decided, that is put back on the pharmacy screen, and the funder then pays the pharmacy in line, or in accordance, rather, with what we have established and what we've decided. We therefore then manage the medicine benefits on behalf of medical schemes. We do a pre-authorization role. The pre-authorization deals with access. In other words, do the patient qualify to have access to certain benefits, whether it be HIV benefit, oncology benefit, PME benefits, and so forth. The patients need to meet certain minimum entry criteria before they are authorized to have access to unlimited benefits and so forth, and they need to join, depending on the client, certain management programs. So we would then be the entity that would also fulfill that pre-authorization role on deciding whether the condition is severe enough and whether the medication is approved for payment from the medical funder. A further role that we do is generic and therapeutic substitution programs to decide whether the pharmacist had the opportunity to give a less expensive generic and whether they actually did that, whether there are any formularies and so forth applicable. Mediscor does that as well. We design and manage a number of formularies, similarly the protocols. Then we also manage some exceptions where people want to travel overseas and they need 3 or 6 months medication to take with them. And we are dealing with humans. There will always be exceptions to protocols and to rules. We need to deal with those exceptions. And then, last but not least, as our core function, we need to reduce the inappropriate use of medication, fraud and abuse. It's also one of our core functions. Then some of the supplementary services, and as far as the core functions are concerned, Mr. Chairman, there is a separate slide that will give you a lot more detail on that specific, on the core functions. The supplementary services, the reporting, we report to the client, the scheme, and the various funders, what happens with their medicine expenditure on a monthly basis. We monitor the disease burden. We make available a contact center. Our contact center is available 364 days a year, all the days that pharmacies are open. We do provider contracting, we do advisory services, we advise the schemes on how to fund medicines and to pay for them. And then last but not least, we maintain a product database of all the medicines in South Africa. There are about 300,000 NAPI codes in South Africa, and we maintain a product database with all of the various prices as we get from manufacturers, as we get from distributors, and also what we get from the Department of Health if it's a scheduled medicine. So, in having previously stated that Mediscore is an independent PBM, there are 4 other PBMs in South Africa. All of them are aligned with a funder or an administrator. And so one would then need to ask and raise the question, why would it be necessary to appoint an individual or a specialist PBM? Now, the first and most important point is that an organization requires significant intellectual property. To know the active ingredient, the price, the interactions of every product that is available in the country is virtually impossible. We also do know that no doctor sees the patient all of the time. You go to your GP for your flu and so forth, you go to a specialist for your chronic conditions, and once you're on a program, you might even make use of a courier pharmacy. So no single provider, whether it be a pharmacy or a doctor, sees the patient all of the time. It is therefore important to have a central patient record where all of this information is brought together and taken into account in the decision on whether a claim is paid or not paid. So similarly, from a provider perspective, no doctor in South Africa or anywhere in the world, and similarly all the pharmacists, will be able to recite all the package inserts that you will find and know all the contraindications and the dosing and so forth. So again, there's significant intellectual property is required to be able to assess and adjudicate a claim at the point of dispensing. So the next point is one would then require high capability systems with real-time clinical intelligence to be able to put and assess and put the answer back on the pharmacy screen. And then this is also the discipline with the largest volumes. So if the medical scheme wants to really have a good impact on their members, and they need to make sure that the medicine space is well managed, because that is again where the member has the most contact with the medical scheme that is in the pharmacy environment. And then last but not least, being an independent PBM, we provide checks and balances where all the information doesn't just come from a single source, being the administrator or the managed care organization. So we do provide some checks and balances with an independent view. So to be a bit more specific, under the pharmaceutical benefit management services, those are categorized into 4 subsections, being the claims processing, the business intelligence side, the client support, where we help them with the design of medicine benefits, and then the consulting side. Sorry, the client support is the contact center and those sort of things. And then I've already mentioned the medicine authorization. The other department is called ChroniLine. To give you some information about the technology that we utilize, it is very, very big international software that we use. It is software that we have licensed since 1998 from a company called OptumRx in the United States. It's the 3rd largest PBM in the United States. They currently manage 3,000 funders, where we currently manage 45 funders, and they also manage 34 million lives on the software that we utilize. OptumRx employs 14,000 staff, and they are owned by United Healthcare, which is the largest healthcare company in the world, where they manage 70 million lives. So the software that we use is internationally very, very well known and very highly regarded software. We therefore have the benefit of all the international development that they do on the software with the 3,000 funders and the 34 million lives. But what is also important is that everything for South Africa we own. So we own the South African version of the software, all the localization, all the developments, everything that has come from the Department of Health or Council for Medical Schemes or our diverse client base, we've developed in our own version of the software. That's the claims processing software we use. As far as clinical content is concerned, we utilize an international product database called Medispan, which we've also licensed since 1998. Medispan is one of the top 3 international product databases. The other 3 product databases are called Lexicon or Facts and Comparisons. And what makes it unique is that where the South African market runs on a NAPI code, there is no intelligence in the NAPI code. Medispan has a unique GPI coding system which has intelligence about the active ingredient of every product. We therefore have the ability to count tablets, to count active ingredients, to count asthma pumps, to count repeats, to apply rules at a clinical level. We can therefore, because we know the active ingredient, we know what the dosing is, we know whether there's a drug-to-drug interaction, we know whether there's a drug-to-disease interaction. So everything of the clinical content is based on the intelligence that we get from the Medispan database. As I said, it's a big database. It's owned by Wolters Kluwer's in the Netherlands, and Wolters Kluwer's employs 19,000 staff. So again, we have access to all of the international research that is done on the clinical side, but similar to what we have for our Exclaim, our processing software, we own and maintain the South African database with all the information about the South African products. I'm just re-emphasizing the point to say that if you want to manage medicines correctly and appropriately, you need to have a central patient record. We therefore would know the age, gender, conditions, clinical information, what is in your blood, what's in your medicine cabinet at home of every one of our clients. So if you go to one pharmacy and you try and go to another pharmacy 4 days later, even if it is a different product, if it has the same active ingredient, the patient may be overdosing, and we will reject the claim to say it's an overdose or an early refill. So whether it's a pharmacy claim, a doctor claim, a paper claim, or other clinical information, everything is read into our central product database, our central patient record, and that would then allow us to do this integrated utilization management and the practicing of pharmaceutical care. Later in the presentation, I will share with you the results of applying these various interventions. So, Chairman, if I could again give a bit more clarity on the few hundred rules that I mentioned earlier. As I said, in the credit card environment, I would maybe do 4 or 5 checks on the transaction. The few hundred we've divided into those 9 main categories. And what is important is each one of the clients have a unique set of rules. I think any pharmacist in South Africa who tries to dispense a medicine product without working through a PBM would have an absolute nightmare, because each scheme not only have unique rules, but they have different rules between each one of the options. So you could have the top option, which can have quite lenient rules, which can have quite lucrative benefits, and you can have a very low-cost option with very strict rules and strict benefits attached to that. So, and it is our duty and our role to then apply, whether it be lenient rules or strict rules, to each one of the various medical schemes and each one of the options that they've marketed and put out into the market. So the sort of things that we would check under the data integrity validations would be just to make sure all the data fields are filled. Under eligibility management, we would check, is the valid pharmacy, is the valid doctor, do the pharmacy have a specific license, do the doctor have a license to dispense, all of those things, is the valid member, is the valid dependent, everything that makes the transaction deal with eligible parties are the checks that we perform under eligibility management. Under utilization management, that is a combined definition that we give for everything that deals with a quantum of medicines that are utilized by the patient, whether it be refill limits, where we can say you can have 12 refills of your chronic medication if it is a 30-day supply, or you can have 13 refills if it's a 28-day supply, or you can get 60 sleeping tablets a month, or you can get 300 analgesics a year. All of those rules are applied under the utilization management category. The items that I've highlighted with an asterisk are the items for which we measure the impact of what we do on a monthly basis, and we report them back to our clients. Later in the presentation, I will show you the impact of those various validations to you. Utilization management takes out excessive use and abuse, and that is really the name of the game. Our statistics are very, very in line with international statistics on what the impact of those various validations are. We attend the International PBMs conference every few years, and it's very interesting for us to compare our results and our interventions to what happens in the international market. If I could move to the next category, which deals with the clinical management, those would be all of the items that you would find on the package insert. Whether it is the appropriate dose for the person, again, the dosing is applicable to the age of the person. So if you're a very young person, if you're 2 or 5 years old, your body can handle a small quantity of an active ingredient. As you go to 20 or 25, you can handle more. And then later in your life, when you get to 50 and 70, then again the dosing is adjusted. So under clinical management, everything you see on the package insert, the drug-to-drug interactions, drug-to-AIDS, drug-to-gender, all of those interactions are done during the clinical management validations. Provider management, where the scheme or MONUSCO has specific contracts with designated service providers, and similarly with the doctors, the appropriate pricing and so forth. Under pricing management, we would check whether it's the correct price of the product, the SEP, or whether it is a non-scheduled or a non-SEP product, which could be how can I say, like an injection or a needle, which wouldn't be part of the SEP regulation. All of the pricing we would check under that. Under reference pricing, that would be the generic or the therapeutic reference pricing. MONUSCO has designed and developed a number of generic or therapeutic reference pricing models where we effectively say that the member can have any one of the original products or the generic equivalents, but the funder will only pay, as if I can give an example, let's say the original product costs R1 per tablet, and you could have some generics at 60 cents, other generics at 50 cents, and other generics at 45 cents. We go through a judgment cycle where we evaluate the various generics that's available in the South African market, and we would then determine a price for where the patients could have access to medicines at a reasonable price. And let's say we decide it's 50 cents, then we would then reimburse at the 50-cent level per tablet or per capsule. So that's under reference pricing, and that drives the utilization of generic medicines. Mr. Chairman, that has been tremendously successful. In the South African environment, we've managed to get the generic utilization in South Africa up to around about 57%. In Namibia, we're struggling to get to 30%, and in Botswana, we're struggling to get to 25%. So it really is, it's been quite an effective measure and a tool to drive the utilization of generic medicines and again to make medicines more affordable in South Africa. Then in formulary management, those are formularies or lists of products. Again, depending on the richness of the benefit of the specific option or whether it is a health insurance product or so forth, the scheme or the funder would apply different formularies, and we would then utilize that to validate the claim. The benefit management is once we've now decided that the claim must pay, we would switch into the computer system of the administrator or the scheme to see whether at that second in time you have benefits available on your savings account, on your chronic or acute or whatever benefit it is. We will then check if it's available. They will deduct that from your benefit, give us an answer. All of those validations that I've highlighted to you in this slide, it happens in 0.3 of a second. The business intelligence that we apply, we report and we supply our clients with reporting models to make sure that they can manage all of the information, that there aren't any strange trends or deviations to what they've budgeted. So we report on a monthly basis back to the funders, the cost per member, the cost per item, the various disease profiles and so forth. And that is on a reporting model that we call medical analyzer. Then the second reporting model that we utilize is the patient experience monitor. Again, it is very important for us to know what happens to members when they go into a pharmacy. Unfortunately, it does happen that the patient is caught in the middle where they charge a specific fee and the funder has a different fee that they reimburse, and then the patient is in the position that they need to fund that difference. Now, that is a concern to us, and we therefore developed this tool called the Patient Experience Monitor, where we track what the pharmacies charge, we track when they could have given us a generic and did not, and we then watch all of the compliance with generic substitution and dispensing fees as it happens on the pharmacy, at the pharmacy. As far as client support is concerned, the item on the screen that I would like to highlight, Mr. Chairman, is that for clinical supervision, we have a pharmaceutical and therapeutics committee, which is under Marlaine's auspices and responsibility. And we have some independent professionals that also sit on the P&T committee. And similarly, our clients and their medical advisors attend the P&T committee meetings, and therefore it is important for us to make sure that all our clinical decisions, protocols and reference pricing have been subjected to very, very thorough and objective clinical review. If I could, before I move to the next one, we've also developed a capability to send an SMS to patients. Unfortunately, patients aren't always advised of what happens at the pharmacy. I'm sure people have experienced a situation where you go to the pharmacy and they say, oh, your scheme is only going to pay 80 rand, and then suddenly you need to fund the difference. Pharmacists aren't always necessarily very good at telling the patients on why there is a copay applicable. Patients won't necessarily know that they were busy overcharging or charging more than the scheme rate, or they could have given a generic and didn't do that. We therefore developed a SMS patient communication facility where we communicate within 2 seconds of the claim arriving, that we put an SMS back on the member's phone to say, please ask for a cheaper generic, or please ask for a formulary product, or your copay is as a result of not going to a designated service provider. Therefore, the patients are educated on what the cause of copayments are, and that they can make better choices at that point of dispensing and while they are in the pharmacy. I've more or less dealt with the communication facility. The next service that we provide is quite comprehensive pharmacoeconomic and clinical studies. Madeleine did her master's degree in pharmacoeconomics, and so we advise the clients, we give them guidance on how to design medicine benefits. And similarly, when there are deviations, we can make recommendations on what to do and what corrective actions that they should take. During the build-up to a benefit year, we work with the scheme's actuaries to again give guidance and to say, well, if this is what the scheme wants to achieve, that will be the costing, and they need to build that into the next year's contributions that they want to collect from their patients. The Chronoline facility deals with authorizations, and we currently do this authorization function for about 29 clients or 250,000 patients, where we would then look at the application for specific benefit categories, whether it be the 26 or 27 PMB conditions, whether it be for HIV, for oncology, for high-cost medications and so forth. We would then evaluate the application and make a recommendation to the scheme whether the product must be paid or should not be paid. So where we need to get more information from members or from doctors, we've got 180 template letters that we send to the doctors, and that we ask for more information to support the claim for the medication. So we go through, and this is a pre-adjudication cycle. So it's not when the claim arrives, it is before any claims are submitted, is to see whether the patient is ill enough to comply with the entry criteria and whether they should have access to the various benefit categories. I could move to the next section, which is our results. Our results have been fairly consistent over the years. As you can see, Mr. Chairman, that utilization management is the name of the game, where you need to manage the consumption of medicine and take out the abuse. The top two categories would result in a rejected transaction, and the bottom two categories would result in the claim being adjusted downwards. So for our client base, we've delivered cost savings and interventions to the value of exceeding 600 million every year. As far as our income model is concerned, we have three types of income models that we get from our medical scheme clients. We either earn a fee per principal member or a fee per beneficiary. That's primarily in the insurance space. And then also there are some of the clients that wants to pay us for the utilization of our services, where they then pay us a fee per transaction. Now, again, when I do a comparison between what we earn to what the credit card companies earn, our fees, even for doing significantly more, are substantially less than what the credit card companies earn. If you just look at your own credit card, you would pay between 38 and 74 rand per month to run your credit card. We operate at a fraction of that. Mr. Chairman, if I could move to a statement of issues, if there are any questions. I don't know if you would like me to just proceed.
Yes, you proceed.
The statement of issues, we've largely tried to deal with items which we did not find in the previous documentation from the Competition Commission, and items that are really, really pertinent to our environment. Therefore, we've listed 4 items. The first one, which is really a big thing, is where we deal with where the administrator also offers managed care services. They have the ability to bundle the services. Again, Mediscor is totally independent. We're not aligned with any one of the administrators. So our ability to bundle is not there. We need to prove value to any one of the clients before we can secure the business. So because they are then out in the market, these group structures, they would facilitate the bundling or the cross-subsidization of some managed care fees. And it would also, they would also find that there could be some layers to the administrative costs. So it is difficult for the schemes to necessarily be able to identify and define what exactly is meant under the various definitions of managed care, and similarly for them to see that sufficient value is derived from those costs. So this obscures the objective evaluation of the contribution made by the various managed care services. And then the large administrators could also then take advantage of this gap and influence schemes to contract services on the basis of cost and not necessarily on the basis of results. In other words, it's very easy to say, well, if I do nothing, I'm going to charge you 5 rand, but maybe by paying 10 rand, you could save a lot more than the 5 rand that you paid. So the bundling and the ability to prove value doesn't necessarily stand out. So all of these factors that I've shared with you, it creates an environment where it's difficult for us to compete, even where our value proposition is what we've highlighted and shared with you. This is just purely as an example. I took one of the scheme's financial statements and just to demonstrate the point that I've highlighted earlier, a medical scheme have published that for managed care services, they paid 384 million rand. There's no breakup, no division between whether it be pharmacy or hospital or dental or any one of the disciplines under that. It's just a combination for managed care services. So that's an example of the bundling that I've just raised with this committee. So from a Mediscor perspective, if I could be bold enough to make a recommendation or to put an aspiration to the panel, is that we would like to see that the Council for Medical Schemes enforce a detailed breakdown of the administrative and managed care cost components, and that be done at the point of both negotiations and contracting. That it's not just all bundled. Similarly, the trustees of the various funders should be in a position where they would understand how managed care is all made up and what the role is of each one of those components, and then similarly what are the expected outcomes that you would want to see that component or discipline delivered to you, and also to be aware of any potential conflicts of interest. Maybe to highlight this point and to, it would be interesting, and it would be this comment would be supported if one looks at the various medical schemes and the administrators to see to what extent schemes make use of external independent entities where the administrator also offer that specific service. And the statistics in South Africa will show that where the administrator offers the service, in most cases, the medical scheme will make use of the administrator. Okay. And it's not independently evaluated. Mr. Chairman, the next point I specifically brought in around the SEP, very specifically in the sense that medicines and the pharmacy industry is the most regulated of any one of the disciplines in South Africa, because both SEP and the dispensing fee that pharmacists may charge are already regulated by the Department of Health. The investigation or the panel has been tasked to say, why is private healthcare so expensive? The SEP doesn't have leniency for volumes. The SEP, whether you buy one product or whether you buy 1 billion of the product, the SEP for that product is the same. So there's no negotiation, there's no volume discount involved. Yet, when the manufacturers deal with the public sector, they buy on the tender cycle, where volumes play a significant role in determining the price, and the private industry also have to pay VAT. So the existence of SEP versus the tender price and the inclusion of VAT in the private sector would definitely have an impact on the private industry being more expensive than what you would find in the public sector. The next point, it is probably a point that where I want to deal with the Council for Medical Schemes and their role from an oversight perspective, in the sense that a lot of contracting for managed care and administration takes place, and where the Council for Medical Scheme wants to intervene is always past the event, which leads to significant delays and also to significant legal costs. What I would like to recommend and suggest is that where big contracts are allocated, that those ones be subjected to regulatory review, which would then not be cause severe delays in the industry and also not cause endless legal battles. And because if you look at the Council for Medical Schemes, their legal costs run to very close to 10 million per year. I believe that if they change their role to more a proactive or a validation position for major contracts, it could certainly speed up decision making, create more appropriate decision making, and also save an immense amount of legal expenses. Then my last point deals with low cost benefit options. There are currently, and I'm sure the panel have heard this before, that there are 8 to 10 million people that are employed with formal employment, but they don't have medical cover. And this is as a result of affordability, or primarily rather. We do believe that the way that the PMB, or the Prescribed Minimum Benefit Regulation, is structured at the moment, it does prevent the introduction of low-cost benefit options within the medical schemes environment. It is interesting for us to see that employer groups can offer medical cover where, and that would be under the Department of Labour, where labour unions offer cover with specific benefits, and similarly the insurance industry. But the existence of the PMB benefit definitely doesn't limit the extent to which low-cost options could be made available affordably in the medical scheme environment. Mr. Chairman, that is the very short presentation. I hope that met with your expectations.
Thank you, Mr. Radman. My colleagues are going to put questions to you if they have any questions, just to clarify some of the issues that you've raised in the course of your presentation. Dr. Bing, you want to?
Thanks, Judge. Thank you very much to the medical team. You made reference to the point that usually the contracts for managed care and administration are sort of bundled to same companies, I think. For lack of a better way of asking this, but how many of your schemes have got administration contracts with the other four, with sister companies of the other four competitors of yours?
Not one.
Not one. It's always been this way.
99% of the cases, yes.
Have you lost contracts that you had serviced well to any of those companies associated with your competition?
Oh, absolutely. Where the administration moved to one of those entities where they have an in-house PBM, or whether an administrator acquired a PBM, it would be very, very shortly after that the medical contract is cancelled. So, I mean, we've seen instances where medical schemes would move their administration to one of the other big administrators, and then all of the other managed care contracts from independent parties would be cancelled and be moved to that entity.
What examples, more recent examples, can you give? Specific names of?
Very recently, Malkur Medical Scheme went to Discovery and they cancelled our contract. The same happened with Naspers when they went to Discovery. We've had an instance with Universal with Tiger Brands, where Universal acquired an interest, or their shareholders, the mutual shareholders, acquired an interest in MediCredit. So yeah, it does have a very specific consequence.
You say that the bundling of services, what you are seeing in the industry is that the pricing is such that it's difficult to know what is being charged for what. Yeah.
That is correct, Dr. Benny, because what we would find is that the administrator will say, well, we charge, let's give an example, 70 Rand for managed care services, and that's for all of it. It includes hospital and PBM and all the various disciplines underneath that. And they're available as a bundle, they're not available individually.
Is it because, in your view, I'm asking you to give me what obviously an informed opinion based on your understanding of the industry? Is it because it's difficult to do that, or it's just convenient not to break the different components apart price-wise?
I think it's both a question of strategy and convenience.
Yeah, you in your presentation, you give us a slide, I think it's on the basis of electronic records, where it's an advantage that you see the client, you can see the history. What if I say, maybe there's the argument that works. If all of my medical scheme clients are under one group that provides a complete suite of services that facilitates my being able to service them comprehensively, or what do you say?
Dr. Bender, it's a very important point that you raised there, in the sense that if that argument is tabled, it would work from the premise that we do not integrate with the admin platform at all. The claim that we have adjudicated arrives on the admin platform 0.3 of a second after we processed it. So although the Discord is there, the administrator still sees the full picture of the member and the client virtually in the same claim channel as what we do. It's a split second later. So it's not that we operate in a silo. It's not that we operate with information delays. The very same claim arrives on the admin platform where they could then again have a comprehensive picture of the patient split second later.
Okay, how integrated is the platform across industry? How much relevant information of patients who are not your clients' members, how much of that do you see?
We see none of that. We only see information from our clients.
And surely it can't be because technology doesn't allow that. I mean, are you saying industry still operates that whatever statistics that you generate are based purely on your clients and you have no sight of that?
Absolutely correct. Absolutely correct, Dr. Wenger.
Has industry ever tried to deal with this differently?
Certainly not at a MediScore level, maybe at a Council for Medical Scheme level or at a BHF level, but from the medicine perspective as such, no, it hasn't happened.
Okay. In terms of all three big hospitals basically told us that on the question of international benchmarking, they can source medicines cheaper elsewhere, other than compared to here in South Africa. I think Life quoted India, Mediclinic quoted Dubai. I can't remember Netcare, what Netcare quoted, but in terms of what you see, your statistics, I don't know to what extent you compare with international trends. Do you see that? Can you confirm that?
Dr. Wengu, I think it is a very, very brave comment to come from any one of the entities. One needs to take the South African market into account. There are two factors. You can't just deal with isolated cases to say, oh, I can get a paracetamol cheaper in India than what I can buy in South Africa. The various manufacturers obviously have some market and a competitive space that they utilize to set prices. Similarly, the manufacturers also have to deal with a public space where they supply medicines in a tender environment. So in the compilation of prices, one definitely needs to take the competitive environment in South Africa into account, and also the government tender cycles before you can just make a bold statement to say, well, medicines are expensive in South Africa. I mean, in our international endeavors, yes, we do see instances where it's cheaper in other countries. But to try and say, well, as a general comment, that medicines generally are more expensive in South Africa than elsewhere, it's not true.
It's not true, or you just haven't looked into it?
We haven't looked in detail, but it certainly hasn't struck us. I mean, we've just come back from an international trip to one of the countries internationally that's looking at our software. The medicines are multiples of what we have in South Africa.
What about the claim that the price differential between an originator drug and a generic is much lower in South Africa than elsewhere?
I don't have enough information to answer that question on the international comparisons with regards to the gap and what the gap is in other countries versus the gap in South Africa.
Okay, without comparing, do you know what the gap is here in South Africa?
Sure.
What is percentage terms monthly?
We recently did a comparison of the top 200 genericized items, and if you look at that, you're comparing the cost of the originator with that of the average cost of the generics available. It's roughly 45%. If you look at the cheapest, it's between 50 and 60%. And I understand that for example, in the USA, that differential is much more. But the comment has also been made that in our market, the originator tends to drop its price after a while. So the originator tends to try and compete with the generics. That's the comment that was made. And for that reason also that differential may be less whereas in the US environment, for example, the originator, that branded product stays there and it keeps its price.
Okay, I mean, just if we were to look at the value chain on the medicine side and the interactions there, what can you tell us regarding the agreements that funders are progressively getting into with the manufacturers?
Certainly in the with the funders that we deal with, none of those funders have, to our knowledge, any relationships with any one of the manufacturers. It is not something where Mediscor plays a role in. It is not something where we supply information to manufacturers on a regular basis on their behalf, or whether we're aware of any kickbacks or anything like that. So, Dr. Bengu, we're certainly not aware in our client base about any one of those ones happening.
I'm not asking specifically, I'm asking industry-wide, not necessarily Mediscor-wise. And I note you first to use the word kickback. I just wanted to know if there are any agreements that funders strike with manufacturers with the interest of getting to understand what's in what the need is, what the final arrangements are, and obviously linking that with the emergence of listing of formularies based at NABICO level as opposed to just generic level. What can you tell us?
Mediscor has very specifically to date stayed away from any formularies that are NABICO formularies. All our formularies are generic active ingredient based formularies. For us to sit here today and to speculate the extent and the quantum of any arrangements between funders and the various manufacturers, I don't think it would be appropriate for me to speculate about that. So I would really appreciate you excusing me not answering the question, because I would just speculate, and I don't think the panel would like to hear speculation.
Accept that. But what is the reason you don't draft formularies at NABICO level? There must be a reason you don't do it.
Well, there would be a number of reasons, and I'm sure maybe Chris would like to add on to what I'm saying. But purely from a management perspective in an open market environment, if you want to ensure access to medication, then you need to make sure that whatever you are putting on your formulary will be available most likely be available in the pharmacy where the patient walks into, or at least the pharmacy would be able to get that medication that the patient would get without a co-payment. And then specifically referring to genericized entities, we've got the originator and we've got a number of generic alternatives available on the market, and where we are setting a reference price. In other words, for example, the originator costs 300 Rand, there are 5 or 6 generics available in the market, and we pitch that reference price, for example, at 100 or 150 Rand. Any of the entities below that will pay in full, anyone above that, the patient will pay the difference. And so from our perspective, I think that's the one overriding factor. It's to ensure that when the patient goes into the pharmacy, you will at least have a fair chance of having that entity on the shelf in that specific pharmacy.
Put another way, if you do it on the basis of NAPI, you increase the chance that the prescribed product won't be available.
So I can maybe add one comment to that. That is doable, but then you would need to have a closed network. You would have to have a patient base that has access to that network, and you would need to have an arrangement with that network to ensure that whatever you are saying should be funded or listed on the formulary is available on the shelf.
Yeah, but what I'm saying is, once you do it at NAPI level, everything else being equal, there is a slightly higher chance of someone arriving at a pharmacy and there is a generic equivalent, but not the one that's specified in the formulary.
That is correct.
What about price? Is there a chance that this arrangement means not the cheapest generic is dispensed?
Dr. Beku, certainly the chance is always there for the cheapest generic not to be dispensed. We are, and because the pharmacies are in business, they are traders, if one may call it that, they would obviously want to optimize their income to the largest extent possible. So if they do have a generic where they could earn maybe a higher dispensing fee, then the chances is there that they would give a more expensive generic. For that reason, we are very sensitive about the dispensing fee that we reimburse the pharmacists, and specifically the current dispensing fee has a break at around 100 Rand. If I could give an example, pharmacies would be paid 30% of the cost of the product up to a maximum of 30 Rand, and that 30 Rand would then kick in at the 100 Rand SEP level. Now, where we are in our client base is that the average generic is very, very close to that 100 Rand. So we are sensitive to see that should the average generic move beyond the 100 Rand, we will adjust that tipping point on where the percentage or the ceiling value comes in. Because we don't want to have a situation where the pharmacist can give a cheaper generic and then not give it because the financial rewards work against them.
Are there any advantages that I may not be aware of drafting formularies at NEPI?
Again, if you talk to 50 people, you will get 50 views and 50 speculations about that. The fact that there are organizations like Discovery that have invested in a courier pharmacy structure, and similarly MedScheme have invested in a courier pharmacy structure, it does point to a situation where they believe that there would be some financial or business benefit to making that sort of investment. It is not something that is applicable in the municipal environments. I can't comment on that.
Is there a potential reason for worry if I'm the administrator of Scheme A? As administrator, I draft the formulary and I draft it at NEPI level. And through my group, I own the distribution chain, which means there's a potential link between what I put on my formulary and what the pharmacy stocks. Is that possible?
It certainly is possible.
Does it open up concerns from a competition perspective?
It certainly could raise concerns, because as much as there could be a reward structure attached to that, if the medical scheme is objective and independent, the medical scheme will need to ensure themselves that all of the products that are on the formulary are economical and efficient products, and that it's not just because the way that the administrator have designed the benefit package and that they bought into it. But they would need to have a look at it at a NAPI level and at an active ingredient, not at a NAPI level, at a generic level, on whether they're getting value for their money.
I think that's a very good point, because look, if the concern that I raised, that are there potential conflicts, is sort of, is netted off by a benefit that ultimately gets figures maybe to the member, maybe then a case can be made. But I suppose what becomes important is then what happens to those financial agreements? Do they reach the scheme, or do they end elsewhere other than the medical scheme? Is that a reasonable question to pose?
It certainly is a reasonable question to pose. How it actually happens in those environments, I can't comment. I really can't comment. I'm not exposed to that.
Now, let's just come to the maintenance of price files. Can you just give us a breakdown of how it works? Broad strokes, which products are listed, who do you distribute those prices to, and what happens with that information? Why is it important? Why are the price files important, and the weaknesses in that system?
The price file is extremely important because it is part of setting standards in the country to know that 300 or 30 Panado tablets have a specific price irrespective of where you go. If you don't have these sort of standards, and we've certainly seen that in other countries, it really causes havoc to funding structures and the ability to budget and to set premiums. So for an organization in South Africa, MediCredit maintains and distributes the NAPI codes, and they have that responsibility. And so any new product that is listed in the South African market needs to be registered with MediCredit and get a NAPI code. As far as the pricing of the products are concerned, one would then need to attach a specific price as directed from the Department of Health on the SEP and the scheduled products. The moment that the Department of Health releases that product, the various organizations like ourselves would then update the price of that NAPI code based on what is how can I say, distributed or regulated from the Department of Health. Where the products are not regulated, as I said, like syringes and so forth, there we would work with industry standards and working with wholesalers and distributors and so forth to set the price for those.
Why is it important that everyone in the value chain understands exactly how much Panado syringe costs? I would assume that's the whole point of standardizing and publishing it the moment it's released.
It is very important because if you want to move to an environment where you know that you are giving your members a pocket-free experience, and that you fund the benefits for whatever that condition is, whether it be HIV and so forth, unless you have a standard for that product and you know what the cost of that product is, you're placed in a position where you would otherwise not know whether your benefit would cover the cost of that medication to treat that condition. So it really is important. If I could maybe ask if Madeleine wants to add to that.
I think, or we think it's important because price files also need to be loaded in the practice management software which are used in the 2,800 pharmacies. And whatever medication is being dispensed whether in a hospital or in a pharmacy, the SEP needs to be standardized. So your price files within the industry are very important, and it also makes it easier to make sure that the correct price is being applied throughout the value chain, and also making it easier to actually measure that regulatory compliance, because SEP is enforced by legislation and regulation.
Okay, but are there any weaknesses that sort of circumvent that, meaning that the price that's listed isn't necessarily the price at which the product is acquired?
I guess there could be a margin of error, but very minimal, because the prices are actually sourced from DOH. But in our experience, nothing of that nature has yet come up. What does occur is sometimes lags in terms of the updates of practice management software, And within our validation and adjudication processes, we're able to pick up on those discrepancies and actually follow it up with the pharmacy or the practice management system.
For now, that's all, Judge. Thank you very much.
Thanks very much. Some of my questions are sort of similar because I think if I understand the way Dr. Bengu asked the questions, I might be asking the same thing. But I still want to ask them. As I understand it, if I'm a member, if I'm a scheme, I will cede all my responsibility in relation to drugs to you. I hand it over and you are going to actually do it for me. So all I do is I make my rules and then I give you the rules and then you do everything else. I stop worrying about that. Is that correct?
It's probably, it is partially correct. We do not have decision-making authority other than on the protocols and the reference pricing that is owned by Mediscore. The medical scheme still has final jurisdiction on the rules that they implement for their members. So what would happen is the scheme would, through consultation with us, design the rules. We would then go through quite an intense interrogation process and going down to specific products, specific rules. And I'm again just giving the example of to say, well, we will apply a rule on your top 3 options where you can only get 1 asthma pump a month or 2 asthma pumps a month or 60 analgesics a month or those sort of things. Each one of those specific rules are signed off by the medical scheme before we start implementing them into the system. So as much as the scheme doesn't give us the responsibility, it is correct. We have that responsibility to then apply all of those rules, and then we report on the application of those rules on a monthly basis back to the scheme. But they do sign off each and everything that we do.
I understand that. And then in relation to, for example, drug choice within a range, so whatever, an equivalent, does the scheme worry about that, or do you worry about that?
No, but if it is within a generic grouping, that would be Mediscore's responsibility to set the price for that generic grouping. It is our responsibility to do that. And obviously, that whole drive on our side is to reduce the cost of that generic group, and similarly to ensure that competition amongst the generic manufacturers are stimulated. And we have certainly seen that happening during the course of our studies on a year-to-year basis, is that the moment that we reduce the cost of a generic or a generic class, the manufacturers follow and they reduce their prices to fall in with that. So within a generic class, we have significant influence on that.
So if I was either a trustee or the principal officer or the member of a scheme, I could come to you and you could produce evidence to me to show me that you're bringing down the costs. I mean, I could come to you and say, I want to charge my members less, or I'm a scheme member and I want to pay less. What have you done to allow me to bring down the costs? And you could show me that.
It's absolutely correct. And if the people at the computer system could maybe just connect to the slide, then I would really appreciate it. Just go back to the same slide as what I am on. It shows our results. Just go back to the slide that details our results. It is probably the 4th or 6th last slide.
I think it's 23.
It's coming up, yeah.
If one looks at the heading that says reference price, that is exactly that point, where the value of the generic reference pricing that we have applied, that is the sum of all of our clients. In 2012, the value was 101 million, and then in 2015, the value was 112 million. So on a line item basis, we could prove results and show that to the clients where we've had an impact on the generic. So that is the accumulation that we've demonstrated there for you.
And do schemes ask you for this?
We supply them with the information and we report that to the trustees when we meet with them.
And
Absolutely.
is it your sense that the trustees or the principal officers are appropriately interested in this information? Do they understand that information?
Oh, absolutely.
They do?
Sure. Big time. Yeah, very much. Both during the design cycle and in the reporting cycle, very much so.
And this is part of your concern around the bundling, because if it's bundled, you're unclear how they would necessarily get that level of detail. So if it came to bundling, I mean, I realize that you are in the drug supply management side, but what would be helpful to us, I suppose, is if someone said to us, you suggest CMS, for example, should have oversight over managed care contracts. What would be useful to us is a document, a short one, which said, if you are going to do this, these are the various, and if you just did for drugs, that would be useful. These are the output indicators that everyone should be interested in. For example, in your submission, you suggest that training of trustees is very important.
Sure.
And so what would be useful is to say, and this is what trustees should be competent in. So if you clearly have that for drugs, if you have it beyond for drugs, could we ask you to give that to us, please? And then I wanted to understand, you were saying the following, that you gave the example of both MedScheme and Discovery having a courier pharmacy investment, and you said this could be pro or anti-competitive, and it depended on whether they were getting the cheapest, the best, and if they were passing it on. Again, for that, if you could you imagine what indicators one would want to have reported to know if it was pro or anti-competitive? Could you provide us with that?
We can certainly have a discussion amongst the team members and then compile something for you. Sure.
And then I know that you're not involved, well, I assume you're not involved in, what do you call it? Consumables. You're only involved with drugs, or are you involved with consumables as well?
To the extent that a consumable is dispensed at a pharmacy, we would adjudicate that claim as well.
Okay, so
and
then...
if it's paid from the medicine benefit, we would be involved in that as well.
Okay, so then the syringe story is relevant to you.
Yeah.
You say we talk to distributors and suppliers. What do you talk about? I mean, how do you come up then with a price?
The reference pricing is not applicable in the non-medicine environment. It's only applicable in the medicine environment. So we would engage the various distributors and the wholesalers on at what price they've acquired the products, and they would give us their list price, and we would then implement and apply those list prices to the claims.
So I mean, for me, they give you a list price. I mean, I could then say, okay, I'm bringing in some syringes, and I print out a list price, and it bears no relationship to my actual costs. I could make something up. So how do you know that they're not?
It's certainly a valid point. They could supply us with a price that is vastly exaggerated or overstated. There we would purely rely on market forces to make sure that the pharmacies purchase appropriately and that the competition in the syringe space would attend to that. But certainly we don't put a reference price or go through a validation cycle on syringes or anything like that. The surgicals are a very, very small component, although there are hundreds of thousands of nappy codes for those surgical items. It is not a big cost element in the medical world.
We've heard, and in fact there's been cases before the tribunal of there being more than one price file. Is that possible?
Certainly there is more than one price file. Each one of the big administrators or PPMs maintain their own price file. So you would find that in the for the SEB, the prices would be, other than the lag that Rufaro was talking about, they would be absolutely identical. In the non-medicine, for the non-medicine nappy codes, there would be differences between the various entities. So the Mediscourt price file, the Medicare price file, the Medskin price file, or the Discovery price file for surgical products, they could be different for sure.
So the cost of something is a product of the actual cost plus whatever muscle one can apply. Would that be appropriate?
Are you referring to the surgical
Yeah.
space primarily? Yeah.
If I was a trustee or a member of a scheme, as a member of the scheme, I'm actually entitled to whatever the trustees get. So let's say I'm a scheme member, and I wanted to know that my scheme was doing the best by me. What sort of information should I want?
Oh, it's a long loaded question.
It's a short question, might be a long reply.
I think the most important, or the two most important elements is that there be no conflict of interest in the various decision making, and that there is sufficient market knowledge and muscle to do the best for its members. To get into the individual competencies, one can break those two elements up into quite a few categories. But if you are dealing with an entity that understands the market and has market muscle, and that entity has no conflict of interest, as a trustee, you would probably have 95% comfort.
Okay. We had a presentation, I think, from dental practitioners, where basically what they said in their presentation was that the managed care components were a method for siphoning off money from the scheme to the administrator. And they went further to suggest that in order to avoid the conflict of interest, that this administrator used that one's managed care and that administrator used this one's managed care. Is this something you think we should pursue? Does it sound feasible, likely, possible?
I wouldn't necessarily support that view. I think that objectivity is important, but to actually be in a space where you outsource to competitors in the market, it will bring a different layer of potential complexity. Schemes are generally very sensitive about their member information and the claims experience about those members. Each one of the medical scheme protects the member information with their lives, and to enforce something where the service model goes to a situation where the information is share between competitors, because the administrator makes the most amount of money out of the administration part, I think will create a certain level of sensitivity and conflict in the market.
Is there any possibility that an administrator can increase their income through the managed care component that does not deliver, that may or may not deliver value to the scheme?
Oh, absolutely, absolutely. It is a defined category. What is done under it and what is charged for it is up to the administrator to motivate. It's not necessarily always tested and checked. Very much so.
I just wanted to check in the lag story. You say you follow up on it, and then what happens? I mean, say there are two ways there are two consequences. They pay too much, they pay too little. So there's some money going the wrong way. What do you do? And how easy is it to do that?
There is no correction that takes place. We just enforce that the correction takes place as soon as possible. In the pharmacy environment, there are effectively 7 software vendors or software houses that maintain pharmacy software, and they update the prices of the various pharmacies in the country. So those 7 software vendors would then distribute the price updates to the pharmacies overnight, or if it's urgently during the course of the day. But it may be that a pharmacist may have a locum working over a weekend or on a Monday evening, and they forget to load the price file that was distributed. It really, really is a small thing, and it's only applicable rarely in the odd occasion. But we never ask the pharmacy to resubmit the price and to reverse the claim and to resubmit it or anything like that. They just have to correct their price file.
Thank you for your presentation. My first question is, you presented us with the overview of your company, and then when you're going through that slide, you mentioned that in terms of independent managed care organizations, you are one of the largest, and that you have 40 clients, and then, but in terms of number of lives saved, sorry, in terms of number of lives covered, you you are not the largest. So what I'd like to know is who are your other competitors in terms of independent managed care companies, and how big are they compared to you?
Mediscor is the only PBM that are not aligned to another administrator or another administrator, whether it be directly or indirectly aligned. There are alignments between all of the others. The largest, or the 2 larger ones, are definitely Medicredit and Discovery. Medicredit manages GEMS, and they would therefore be bigger than us. And Discovery has an in-house PBM, and they manage the Discovery Medical Scheme, and they are larger than us as well.
Then my follow-up question is, then you on one of your slides on recommendations, I think your first recommendations under CMS is that the regulatory framework should include the advanced right to review tender allocations. So I'm just wondering, could you explain to us what is the tender process, and how do you apply for these tenders, given the bundling issue that you explained, that administrators would offer 2 services and you would be offering 1 component? So how are the tenders advertised, and how do you then apply?
It's quite an important question that you've just asked. Where the medical scheme puts out a tender for managed care services that are bundled, Mediscor would not tender, and we wouldn't have an opportunity to participate in that because they have bundled the services. The only entities that could then participate in the tender would be other administrators that also bundle the services. There has been some instances where some of the individual managed care companies got together and we created a bundle of independent parties, but it's quite a complex process to go through. I would say by and large, the independent entities would then not participate in the bundled tender. To share a bit more information about tender processes in the medical scheme environment, they are very, very different. I mean, some of the tenders are very comprehensive, detailed tenders where third parties are used during the tender processes. I don't necessarily agree with third-party tender cycles, but that's a personal view that I have. Some of the tenders are very, very detailed and comprehensive, and other tenders are as quick and simple as requesting 3 or 4 parties to submit a proposal. So to generalize and to say exactly how tenders are, what is the right word? To say that the tenders are long, drawn-out, complex, intense processes. It's not always like that. They don't always specify the various components. Sometimes they're bundled, sometimes they're not bundled. I don't know whether that answers your question.
So in terms of your recommendation that the CMS should review the tender processes, do you think that the tender processes should be standardized, or are you happy with the variations that exist currently?
I'm perfectly happy that the trustees be given enough leniency to do a tender cycle and a tender process the way that they want to run it. I think, and this is exactly where my sensitivity on the matter comes out, is where organizations or appointments are made, sometimes some of the players or organizations like ourselves in the industry have been, we've raised our eyebrows to say, how did this happen? Nobody goes to a certain supplier for 8 years and then suddenly they win this tender. And we say, but how did this happen? Nobody's ever gone there in 8 years and now suddenly there's a tender awarded to them. Similarly, you have instances where the Council for Medical Schemes would raise questions about tenders that were allocated and appointments that were made. But then it's 2 years after the event, and then they need to go through legal processes and trying to unravel things. I just think on the big tenders, it would be quite important for the council to just be informed on the decisions that were taken.
In your response to a question posed by Dr. Bengu, if you have lost clients to legal administration with budget services, you said yes. So I'd like to know if the reverse has ever happened, that an administrator would switch and come to you living there. Medical scheme would switch leaving their administrator to contract you for managed care services.
We have in very, very rare instances had a situation where a medical scheme appointed Midiscor to deliver PBM services where the administrator also offers that service. There aren't any of them at the moment amongst our client base. It is a very, very rare instance. So we have, let me rather put it this way, we have 2 small clients that are with an administrator that has, are aligned with another BBM, but that is a rare situation.
Just to complete the questions on the CMS, so on that same slide, you mentioned disagreements. I'd just like to know if you have any personal experience with having had disagreements in your contracts or any issues regarding any interactions with the CMS?
Metascore is an accredited managed care company, and we are subjected to the accreditation cycle every 2 years. Our current accreditation runs to November this year. So the council does come to our premises and they subject us to quite a comprehensive review. And the council sends a team there and they spend 2 weeks at Metascore where they go through all of our contracts. They review every contract, they review our protocols, they review a lot of things during the visit.
Then my next set of questions is, on one of your slides you mentioned that medical schemes use different formularies, and you also mentioned that these should based on are evidence-based. Much has been said by various stakeholders on the questioning the evidence base behind the formulary. So I'd like to get your view on.
Yes, definitely. In designing our formularies and also taking into consideration that most of these formularies have been running for more than 10 years in our environment and they've evolved over the years, and I think they have stood the test of time. But there are also new medicines coming onto the market, and especially your speciality, your high-cost medicines, and there definitely it plays a big role in determining how one will be funding those medicines, whether they are even added to a formulary or not, or whether that it's a product that will simply be managed by exception and a decision made around that. Just to put the process a bit into perspective, we do, I think Krista mentioned that we have a pharmacy and therapeutics committee, consists of internal clinical staff, and we've basically got a structure where we have a main committee, then we have a clinical task team and a technical task team, and the function of these two teams is to do, on the one side, the clinical evaluation, and on the other side, the implementation of whatever decision is made at the main meeting. So at the main meeting, we would put together all the evidence and the recommendations, both from a clinical and a financial, and where we feel this product fits in considering these different levels of formulary. So we may have a recommendation that on your very entry-level medical scheme option with a low contribution, this product is maybe not relevant to be funded, or it should be funded under these and these circumstances, whereas in the high end, this is the recommendation around funding. So yes, all of those things are definitely taken into consideration. I don't know if you need a specific question.
So you would then expect that across a similar option on different medical schemes, you would have similar, if not the same formula used, because all medical schemes have a similar interest, which is to serve their members in terms of the quality of care and cost. So why then is there such variation?
I think the variation simply stems from consumers that want to buy different kinds of products, and the affordability to the consumer may differ. Buying an entry-level option where you have hospital cover and potentially only PMB cover, to a very comprehensive option where you've got all the bells and whistles, where you've got a full dental benefit and all these other things. And there's a distinct difference in the contribution that you would pay on the bottom option and on the more comprehensive option. And in line with that, we've designed these formularies. So typically, the basis of it all is around specifically the CDL, or chronic disease list conditions, where the algorithms are in place and where there's a very specific guideline around what the minimum benefit should be. So the first step there, from our perspective, is to ensure that we comply with that requirement and that the minimum benefit is there. From then onwards, we would be adding more richness to this formulary up until we get to the highest level. So I can ensure that entry-level option gets what's entitled with regard to the prescribed
across all medical schemes. then I think my last question, which is on the PMBs, you showed a slide on business intelligence, and that you do industry comparisons and profiling. So I'd like to know if, I'd like to get your view on what has been the impact of the introduction of PMBs on managing chronic conditions.
It definitely had an impact. At the moment, the PMB cost that we report, and remember that's medicine-based, and it's mainly around the chronic conditions, the chronic disease list, a few other PMB conditions where medicine therapy is relevant, is around 33–34% of the total medicine expenditure. So it does make up a significant portion. Initially, when the CDLs were introduced, we did impact analysis, and remember at that stage, you didn't have a diagnosis, so you made a proxy diagnosis based on the medication that was used, and at that stage we estimated that about 80% of the current chronic expenditure at that stage was for CDL conditions. What we also see, and I'd be happy to share those numbers with you, and I think it's all things that we have published in public forum, the increase in that percentage of the overall medicine expenditure has gradually increased over the years. The last 2 years, we've seen it sort of stabilizing at the 33–34%, but we have seen an increase since inception.
So you've answered in terms of expenditure, but in terms of outcomes, in terms of quality outcomes?
I think there we are working in the medicine environment, and ultimately the outcome is something that we need to measure on, especially on the hospitalization side. And that's where you would need to sit with your clients and with the scheme and look at these specific numbers and look at the outcomes and look at how it differed 5 years back from now. Also, it's a very much, when you're looking at chronic conditions, we're looking at a long-term view. And one may not necessarily already have sufficient outcomes to measure for your existing patient pool, but that it's something that's relevant, and I think that industry needs to pay a bit more attention to. I think it's true. CMS is in the process of, where they do have an initiative with the IT activities, where they are gradually creating these kinds of outcomes measures that could be an industry standard.
Just to explore that a bit further, it seems to me that one possible process measure that you could contribute to is compliance. So you could generate that information yourselves, couldn't you? Because I mean, in theory, if someone's on their antihypertensives, there's a hope that they are avoiding other potential negative outcomes. So do you have that data? Is it possible to get that?
Yes.
Could you give that to us?
Good condition.
Yeah. We can, I mean, I think if we went with hypertension and diabetes, that would.
Yeah. No, we certainly track and report compliance to our clients on a monthly basis. So, and then generally the clients would have a disease management team that would follow up with their patients that don't comply. And so the extent to which the patients comply, and in fact it is very, very interesting how diverse and different the compliance between the various conditions are. And we can certainly, we'll supply that to you.
Well, thank you. That was my next question.
Thank you.
I would like to try and understand the market a little bit better. That you have been speaking about the market. You have been talking about you are the only independent PN in the market, and your next competitors are. You know who your competitors, precisely who your competitors are. Your next competitor is Medicredit, not an independent competitor.
Medicredit as far as Medicred is concerned, there is a shared shareholding between the owners of Universal and the owners of Medicred.
Right. Right. Forward, isn't it? And then this discovery, of course, and do the other administrators, Medsky and Metropolitan, also have their integrated MCO facility?
Medsky has an integrated managed care service that they do, which includes a PBM. Metropolitan still has a relatively small component of a PBM function that they have. From the time that they lost Polmed and GEMS at the beginning of this year, that component of their business has scaled down dramatically.
All right. Okay, and if I look at the MCO world, the world of managed care organizations, I see sort of the generic function that every possible healthcare related cost is being managed, could be managed, and I sort of tend to think of you as a specialized player in that field, of pharmacies, yes. Are there more specialized players in other fields of Glencore fields?
Yeah, very, very much so. There are specialist organizations in the hospital environment, there are specialist organizations in the radiology, in the pathology, in the dentistry, in the optometry. So in various disciplines, there are some independent specialized organizations in each one of them.
Right. So we have specialized ones, which are the majority, they're specialized in their field, and we have generic ones that offer all these specializations in different parts of their office.
Yeah.
All right. That's interesting. Now, what I want to
sorry, could I maybe just elaborate a little bit
yes, go on.
on
Yes,
that? And what you will find is that the biggest market share is held by the bundled organizations, be it Discovery, Medscheme, or Metropolitan.
How much?
Definitely more than 60%.
60%.
More than 60.
And that would relate also to other, that would apply also
Yeah.
to other specializations.
Yeah.
So there's
Very much
specialized,
so.
etc.
Very much.
Right. Now I would, thank you very much. I understand that a bit better. Now I would like to go into the question whether there is, you talked about bundling, and you sort of alluded or suggested that, you know, the way that, for example, one of the big competitors behave, they have an administration function, they have an MCO function, and they contract a new closed scheme, or restricted scheme, might be your client. A couple of months later, you find out that the client also, in terms of its pharmacy benefit management, switches to Discovery. Is it possible for you, is it in your experience, do you think it is possible for a closed scheme to enter in a contract with Discovery without making use of its MCO functions?
It certainly is. There are examples where both Discovery and Medscheme and their clients make use of external organizations. So it is not a situation where it is 100% or nothing. There are
a forced situation.
Yes, it is not enforced to the extent that it is 100% applied. It comes down to a level of the way that it is sold and the way and the extent to which there is a value proposition or a package that is offered. There are certainly examples of some of the clients in both Discovery and Medscheme and Metropolitan where they do make use of independent third parties.
Right.
It's in the minority, but it definitely is there.
Right, so it is possible.
It is there.
Is it possible, and you talked about the sort of the way that the contract is diffuse or not very clear and transparent, and that's one of your suggestions to make these contracts more clear in terms of what is being paid for, or what is being intended for. Sure. Right, I understand that. But is it possible, do you think? So your suggestion was more or less there is cross-subsidization going on. There is a sort of mist around what is precisely paid for. These schemes and trustees are not really, especially maybe the trustees of the smaller restricted schemes are not well placed to make a precise call on what is being offered. So that could be improved upon. Do you have examples? Do you have firm examples of cross-subsidization between the administrative function and the NCO function?
I don't see any one of those contracts. So it is something where there are rumors and there are comments, but I don't want to list specific examples where I haven't had direct exposure to the extent that it has happened.
It's more your gut feeling.
Yes.
Right.
And also from the example that I have showed on the way that the medical schemes report their expenditure. And, if I could just also conclude, and the way that the tenders are issued. Okay, so one looks at the content of the tender and what is asked for in the tender, and then one can apply a certain level of judgment to say to what extent is there sufficient understanding, to what extent do the trustees believe, and it could be out of a lack of information or ignorance that a bundled service is the way to go.
That's right.
So by looking at the way the tenders are written, by looking at the way that the reports are done and the contracts are done, it is from that basis that I'm making that comment.
Could it, Mr. Radman, could it be the way to go in the sense that could there be sort of economies of scope that play a role in a bundled MCO function, or maybe even broader in a bundled MCO administration function? You explained to us that your IT and your intellectual property, so that your know-how, but also your IT investment is quite a chunk in your total asset value, I think. What would you think that the IT investment and your investment in systems represents of your total asset value, including buildings?
The IT is it's a huge thing. We haven't seen any new PBM entering the market over the past, I would say, 10 or 12 years. Both the ability to put the IP together and the IT together, it's a really, really big thing. It would certainly be in the region of about 50 million rand to get going. And then you need a client base to support that. And the break-even levels are quite significant because the entry barriers are huge. The margins that we work on are just so small that you really, really need a significant client base to be able to fund that.
Now the other, so what I'm right now, that was my next subject, very essential. I'll go into that now and come back to later what I was going to do. So you say it's quite hard for a new player to get into the market, both in terms of IP and IT investments and in the client base that you have to gradually build up, and it's enormous lag that you have to sort of surpass. I quite understand. How hard would it be for one of your other specialized MCOs? They have IT in place also. They have to invest a lot in IT. They have to invest a lot in IP and also in investing in getting all there is to know about schemes clients. So they have to put it in. So they have a sort of an advantage in entering your market. How hard would it be for a colleague or a competing specialized?
I don't think the situation are that much different between them and a new entrant. And I'm specifically making the comment, in the pharmacy environment, the majority of the work that we do is medicine specific, and also we operate in real-time claims processing, where we do high volumes of claims on a day-to-day basis. If you look at the other disciplines, whether it be hospitals or radiology or pathology or dentistry, very rarely would you find a real-time claims processing environment in any one of those disciplines. So although they may have IT to develop systems that would apply the level of clinical rules and to convert databases and customize databases to what is applicable in the medicine space, it will still take significant investment in time and time.
Yeah, I understand.
So there could be a saving if they have a large footprint of clients that they could possibly convince to move. And they would then also have to deal with a competitive environment of saying, okay, how do I motivate a value proposition? Because if they go in with a price, it's just going to make their break-even point lower, and also and then they would need more volumes. So it certainly is a difficult market to enter, whether it be from an administrator point or another managed care organization.
So,
and we have been here for 26 years, and every year we have seen the margin squeezed. Yeah.
the margin squeezed, and also your competitors come up, but you don't expect now that the market in terms of competitors is saturated. You don't see any competitors coming in anymore, only getting out.
I don't think any one of the players will get out. I think the people that are here at the moment are going to be here for many more years. I don't think anybody is going to leave the market unless something strange happens with clients moving or clients being taken over or moving administration. But I think the four bigger PBMs that are here at the moment are here primarily to stay.
So we have a sort of funny mind game in antitrust economics where we do this mind game with you, but I do think I know already the answer. And that is you and your four competitors, are like 3-4 competitors, form a cartel, price cartel. You raise prices with 10%, and they fire you because you object to that, so you're out this time. And now the question is, could you, with all your knowledge of the industry, within a year set up a new company that would be viable under this umbrella of 10% price rise? I think it's a puzzle, but think about it. Is it possible?
Yeah. I don't know specifically how to answer the question. I do know that the competition between the organizations are alive and very well, and if I can put it kindly, we all participate in tenders and we all try our best to gain market share. So it's a very, very alive competition between the four players.
Let's say a hypothetical situation. Of course, it will never take place in reality. A lot of what we economists think of.
And it's illegal. Yeah.
Is it possible to set up a new company in a year's time with your know-how, with the backup of finance?
It is.
It is possible.
It is.
And then the client base.
If you ask me whether we can clone Mediscore and call it Mediscore B and have different directors and different, approach the market, we would have to make our systems and servers and things available to them. It is possible.
One last question. That is, so we have these administrators also developed a managed care function. And they manage sometimes they do manage to compete, of course, because they have the majority of the market. Right. And there could be some cross-subsidization going on, but there could also be some real economies going on. Can you go into that subject if you now tell me what's sort of economies of scope I should think of if I think in that direction?
In one of the, for an administrator to cope, you would definitely need a large client base. You need to have sufficient income streams to invest in clinical competence. You need enough volumes and income to invest in IT structures and to attract very, very good staff. So to compete on systems, the product, definitely economies are key to the thing. At the end of the day, you have a consumer out there that wants as much as possible from his medical scheme or his health insurance, and he wants to pay as little as possible, because any health purchase is essentially a grudge purchase. So yes, we do want it, but we also want to know that it is comprehensive, and we also want to know that it's reasonably priced. So every little bit that, whether it be us or the administrator, that adds to that healthcare rand, makes the premium that the medical scheme charge at the end of the day makes it more expensive. So the consumers also vote with their feet. So the extent to which the consumers would then buy medical schemes that are economical and so forth, that puts pressure on everybody in the supply chain, whether it's administration or us, to make sure that we remain competitive, that we invest in proper IT systems, that we invest in proper clinical competence to make the right decisions and so forth. So the pressure from the consumers and the broker market, it puts pressure on the whole chain.
Yeah, I do understand that. So you looked us very impressed as well from here. No, but what I meant to ask you, is it possible that per claim that you deal with 100,000 to 150,000 claims today at a certain cost on average?
Yeah.
Is it possible that you put your practice in the discovery organization and the cost per claim dealt with would be lower in that organization, because you can share investments with a larger organization?
It certainly is that there are some of the items in our cost structure that is a direct cost that goes with the volumes, and there are other items that are fixed cost, whether it be buildings or staff or the servers and so forth. The bigger organizations does have a lower cost structure per unit, and so for the PBMs to be competitive, you need quite a significant break-even point. It really, and it is real. It's that Discovery has a large footprint, and they have large volumes, and they can deliver it at a good price. It's true. And the same with MediCredit, where they have gems and so forth. We don't have two big clients, but we've got quite a significant footprint amongst a list of other clients. So between the three of us, I think our cost basis, I would be surprised if the cost basis between the three of us are that significantly different. And we also see it with the extent to which the competitors and the pricing between the three larger organizations come out with. And sorry, I was going to add a mid scheme as well. They also have a fairly large footprint. Between the four of us, I mean, when we go into the tender cycles and so forth, the pricing are not that vastly different.
Thank you very much.
Thank you. When you see between the four of us, who are the other three?
We have MediCredit, we have Discovery, and we have MedScheme. And then the portion of Metropolitan that is smaller, that is still left in Capital. They are not at the volumes where Medisco and the other two are. Other three.
So that is MedScheme?
Yes.
And then what? The other one is with Discovery?
Yes.
Right. And the other one?
MediCredit.
MediCredit.
Yes.
And
Metropolitan has a functioning.
Metropolitan.
Yes.
Yes, I understand. When you entered this industry 27 years ago, how many of you were there?
There were effectively two of us. It was us and Medicredit. Medicredit originated from the Pharmaceutical Society of South Africa. It used to be a company called PSSA Contracts. So it originates from the Pharmaceutical Society. There were just two of us.
And since then, you appear to be one of the two that have survived outside of the medical scheme for the years.
We certainly have survived. The PBMs were also acquired by administrators. The PBM that Discovery runs used to be an independent PBM that they acquired. Medicredit used to be independent. They now have a cross-shareholding with Universal. MedScheme acquired an independent PBM called Interpharm, and Metropolitan developed something in-house.
So, over the years, more have emerged from the two.
That is correct.
Right. And what has happened to those?
They were acquired by the administrators. The third one that entered the market over the years were Interpharm. Interpharm was acquired by MedScheme. So Interpharm now is owned by MedScheme. Another one entered the market called Pro PBM, and Pro PBM was acquired by Discovery.
So those who have survived it yourself, is it Medicredit?
Medicredit still exists today, yes, very much so. They run GEMS.
They what?
They are doing GEMS,
Oh,
the GEMS medical scheme.
Are they affiliated to it?
Pardon?
Are they affiliated to?
No, they are affiliated to Universal Health, one of the administrators.
Oh, one of the administrators. Oh. But
They were acquired, they used to be independent, they were acquired during about 18 months ago. The shareholders of Universal are the same shareholders, but it's not a group structure, it's individuals.
Yes. But from what you're saying then, that you are the only independent PMP, that's right?
Yeah.
Why is it that there's just one PMP? No, PBM, I beg your pardon.
If you ask me whether we're the last one holding out,
And the question is for how long?
At the moment, we deliver services to a segment of the market that requires an independent PBM. There are 16 administrators that we work with that don't have an in-house PBM. And if we, for instance, are to be sold to one of those administrators, the other clients will feel very, very threatened, and they would not be comfortable with us being sold. Where Mediscor finds itself is that we are very, very comfortable with our positioning in the market at this point in time. And I'm not saying that we've never been approached, we have been approached, but the independence works for us.
Of the 40 clients that you work for, how many of them have got administrators in addition to you working for them?
All of them. All of them. Each medical scheme needs an administration function. Some of them outsources the administration to an external specialist administrator, and some of the medical schemes administer themselves, and but all of them would need that function to be fulfilled.
Yeah. So all of your 40 clients have got administrators?
Not
No.
all of them, because Because some of them administer themselves.
All right.
Like a basement medical scheme, they administer themselves,
Yeah.
and they are a client of ours.
Yeah.
So we have clients that administer themselves and some clients that outsource to the administration.
Okay. So PBMs are able to work together with administrators. Okay. And that doesn't give them a problem.
No.
Okay. So the appointment of an administrator does not in itself pose a threat to your existence.
Not at all. We don't compete with the administrators whatsoever.
Yes. Okay. You mentioned that the biggest PBMs have got 60% of the market.
Yeah.
Okay. Who are these?
Discovery and Medicredit.
And
They would be the two bigger ones, and then I would.
that is only two.
Those
Those two
two.
would have 60%.
Yeah, and then between us, Metropolitan and MedScheme, we would have the rest of it.
What is the source of this information that you give us?
It's the number of lives that are managed by the various PBMs.
Is the what?
The number of lives, the members that are managed by those PBMs.
Yes, I understand.
Mr. Chairman, I'm just giving round numbers. Obviously, depending on when you count, it could be a little bit up or a little bit down, but it's a broad market perspective.
I understand.
Yeah.
Now, I want to take you to the third slide from the end. I think that's where you talk about the regulation of pharmaceutical chain. In particular, where you say there is no opportunity for private sector to negotiate the SCP based on volume, while public sector pledges tender prices significantly lower than theirs. So, what are you suggesting here? Do you wonder what are we supposed to do with this?
Mr. Chairman, it is an attempt from my side to give some explanation on why there is such a significant difference in the cost of pharmaceuticals between the public sector and the private sector. In the sense that the public sector can negotiate tender prices. They don't charge VAT, whereas the private sector do not have that opportunity. It is me giving an explanation for there being such large discrepancies.
As a matter of interest, the process that you described to us takes at the most about 4 seconds.
Yes.
Yeah. It must be simple. It must be a simple process. I mean, using the kind of technology that you're using.
It certainly at face value looks simple. The pharmacist captures the prescription on his pharmacy screen and he hits the enter button and an answer arrives.
I understand that, but it just seems to me if you could do what I would have thought it's such an involved process, if you can perform that in about 4 seconds, then surely it must be a fairly simple thing to do. If they have the technology.
If you have the technology and you've developed everything around it, to do it, take on, because I don't understand the word simple. Maybe I need to understand that word better before I could respond to that.
Well, if something is complex, I would have thought it takes some time. I mean, something that's a matter of seconds. But before I utter the next word, you're done. I'm sure it must be simple.
Mr. Chairman, there are many, many years of technology and development that sit behind these solutions. Yeah.
I mean, does the service increase the cost of running the schemes?
It reduces the cost of running the schemes because it eliminates inefficiencies, it eliminates abuse, it eliminates medical errors, it reduces the cost of the medication. So those savings and interventions that...
So it enables the schemes to save a lot, doesn't it?
It does.
Yeah.
It does.
Of course, they do pay for the service.
Yes.
If they were not paying for the service, they would make a significant savings. If they were to do it themselves.
The value of those savings and the interventions that I have reported are significantly more than the medical income.
But if medical schemes were to do the kind of service that you do themselves, which doesn't seem to me to be that much involved because it just takes a matter of seconds. If they have the right technology, they could not only save on cost, but it could also save on the fees they were paying to you.
Mr. Chairman, the comment is correct if they have enough volumes.
Yes, I understand. Yeah. Now, you have been asked this question, hopefully, and that is, how easy is it today to enter this market?
We haven't seen a new entrant for probably 10 years. I think it's relatively difficult.
Why?
Because you need, first of all, the IP. You need the databases, you need the software, you need the people, you need the protocols, and then you need to have a sufficiently large client base to justify the investment.
And how are these PMBs remunerated? Is the percentage on how many medications you process, or how many? Is it per day or per second? Per second will be quite low.
We earn the majority of our income per member, which is similar to the income what the medical schemes earn on the contributions from their medical scheme patients. So that's the majority of our income that are paid like that. Some of our clients pay us per beneficiary, and that's primarily in the insurance environment. And then we have a small portion of the clients that pay us per transaction or per claim that's paid. And that's how our income is made up.
Yeah, okay, all right. Now, is there anything that you would like to draw to our attention, which perhaps you haven't had the opportunity to raise with us today?
Mr. Chairman, I really appreciate the opportunity to have been here, and we've certainly applied our minds to the items that we have listed, and from my side, nothing new.
Yeah, I think it only remains for us to thank you for your patience and for keeping you this long. You're not used to this long time. You're used to seconds. So we should develop an inquiry that would be a matter of seconds, so that you are in and out, and then we can deal with as many stakeholders as we can possibly afford to deal with. But that said, thank you for being here. To your fellow members, well, thank you so much indeed.
Thank you for being there. I really think the industry needs this inquiry, and I really, really look forward to the next few years of seeing positive change in the industry. Thank you very much for doing that.
Oh, by the way, that just reminds me that I would have prepared. I would have remembered this. And that is the information that you owe us. Oh, wow. When we can look at that?
Probably in the next 2 weeks.
In the next 2 weeks,
Yeah.
yes, okay, very well. It would be grateful indeed if you could provide that information. Thank you. We've now come to the end of these public hearings. The next sets of hearings will commence on the will commence on Tuesday, the 17th of May in Durban. They'll run until Thursday. Thank you.